Okay, good morning. I think we're going to have a few stragglers coming in still, but I just wanted to welcome you back to SCUF 17. Good morning. Just a couple of updates for the schedule. We have a full day today with a lot of great speakers, a lot of great topics, hoping for some lively discussion to continue on like yesterday. If you look at the schedule, we're starting off this morning with this great panel of literature for ultrasound fellows, but it's also must-know literature for us who are teaching. And then at 9:30, we're going to break into this split curriculum. I don't know how to make this stop. So we're going to break into the split curriculum. So the ultrasound fellows will go to the breakout sessions, while this room will continue with PEM ultrasound training, critical ultrasound training, and fellow competency assessment. And then we'll merge together again at the break. At the lunch break. So at 9:30, fellows can go down the hall past the bathrooms. There's one classroom down at the end of the hall on the right, and that classroom will have a HeartWorks simulator. Now I know people were very excited when they got the initial packet about Mike Lewiss, the first ultrasound fellow teaching them TEE. Well, by now you're a little disappointed that you find out that he's actually the 5th ultrasound fellow. So if you're recovering from that blow and still excited about it, unfortunately, Mike's 100,000 miles in the last 3 weeks have caught up with him, and he's stuck in Atlanta. So he's not going to be able to make it here in time. We still have the HeartWorks simulator. It's getting set up down there. We have Cameron Baston is agreed to step up and basically have a hands-on scanning session for anyone who's interested, going through the views of echo, and we have a lot of great cases built into the simulator. And that'll be a great way to start off this small group session, meeting your fellows from around the country, your co-fellows, and then those fellowship sessions will start out and continue on with some sessions on teaching, some administrative topics that you kind of thought you didn't have to know until all of a sudden you realize now you need to know. Your new boss is going to want you to know these things, and then finishing up with Arun teaching some hands-on nerve block session. Okay, without any further ado, I'd love to introduce our next panel, who are going to talk to us about some of the best literature addressing a few topics here. And I'll let them go ahead and get started.
Good morning, my friend, again. I hope that you saw all the fellows that are here already. I think the majority of the people that I see, all young faces, most likely they are all fellows. That's great. So we are working on we're going to talk about this must-know literature for the fellows, but really, basically, I can say with my experience myself that I'm just presenting 2 of this article. I went through all this literature in the last 2 years about the topic that I have, and at least I had 24. I need to cut it down to really 2. So these 2 they are really good articles, and there's a good kind of discussion already started, and pretty new, just like 2017, and the same for all the rest. Let me introduce the panel. We have John Kendall is from Denver, Colorado, and we have Dan Theodoro, that he is from Washington University, and we have the Dave Billihar from the University of Massachusetts. So we are pleased that we have this all group of experts here that actually they are going to give you this, the way we are going to do it, we are going to present one case, one article, and Dan is going to at the end just give us a critical review on that article. So there is not really much time for question and discussion, but we are hoping that if you have really interesting comment, please feel free to say it, or just at the end of the session we can talk. I'm asking John, please just start with your articles.
Great, thanks. So we've got a bunch of ground to cover, so I'll go ahead and get started. I'm going to approach this, first of all, with some clinical questions, things that I thought would be good for us to go ahead and answer. For instance, how does ultrasound actually compare to the CT scan? Can ultrasound actually be used for clinical decision-making? And then lastly, does it really matter who performs the studies? And then we're going to be asking Dan to actually answer those questions for us. You can do it. I know you can. So the first study, we're going to look at a New England Journal of Medicine study. And if you're thinking about what should I aspire to in my career? It's to publish in the New England Journal of Medicine. If you think about it, the impact factor on the New England Journal is 59.5. The next closest is a Lancet at a mid-40s or so. And so by far the highest impact factor journal out there. So this is a good study. We'll see what Dan can do with it. It was a prospective, multi-center randomized comparative effectiveness trial. Patients aged 18 to 76 who they suspected had nephrolithiasis were enrolled. About a year and a half of enrollment. The intervention, there were 3 of them. You either got randomized to a point-of-care ultrasound, a radiology ultrasound, or a CT scan. And what they looked at in terms of their outcomes, primary outcome was 30-day incidence of high-risk diagnoses, 6-month cumulative radiation exposure, and then they had a number of different secondary outcomes that they looked at as well, as you can see up there. This is some of the results. So actually, can we, yeah, it's hard to see. So initially they had about 3,600 so patients that they enrolled. Ultimately, they included a little over 2,700 in their population. And then they randomized 908 to the ultrasound group for point of care, 893 to the radiology ultrasound, and then 958 that went into the CT group. And this is some of the data, and I'm just going to highlight things that I think are important, and then Dan is going to dispel any of that. So the first thing that I thought was history of stone disease was relatively similar in each one of the groups, around 40% or so, low 40%. Evidence of hematuria in all of the groups was about 60%, little above that, so they were fairly even. But yet almost all, or at least 60% in all of them had hematuria. And then they asked the docs to classify what's your probability, what do you think the incidence of stone is going to be? And you can see about 40%, 35, 40% thought that it was at least 75%. If you add on greater than 50% chance to that, each of the groups, it was around 60%. So these are groups where they suspected they had stones and they all had hematuria. And then if we look at some of their other data, one of the primary endpoints they had was radiation exposure, both short-term and long-term at 30 days. And you can see the ultrasound groups were significantly less when they compared to radiology. They also looked at the length of stay. That was another significant factor, and it was decreased, and we'll show some data in just a little bit about that. And then they also looked at the sensitivity and specificity of each one of these imaging approaches, and it was equal across all the different ones. So about 85% or so sensitivity, specificity was right around 50% or so. So the limitations or the outcomes that they found, conclusions were ultrasound was significantly less radiation exposure, about half of that of the CT group. There was no difference in the high risk outcomes, nor were there any difference in the secondary outcomes that they looked at. Length of stay was shorter in the point of care group, and that's something that we know. If you just looked at that group in total, it was about 0.7 hours. But if you looked at the folks that only had an ultrasound, they didn't get a CT, it was about 1.3 hours. Although 40% of the group, the folks in the point of care group, ended up having a CT as well. So it wasn't the only imaging modality. If they felt like there was an indeterminate finding, then they went on to get CT, and that was compared to 27% in the radiology group. So Dan, does ultrasound compare to CT? And before you start, keep in mind, you're going to be critiquing a journal that has an impact factor of 59.5. No pressure.
I have nothing to say. No, I'm joking. Well, thanks, John, because as you've alluded to, this is very, very difficult to critique. It's a very well done study. My theme today for all the critical appraisal, and let me first start off by saying that if we landed on one of your papers and I'm critiquing it, I first of all applaud you, because to do research is very difficult, and all the studies that we chose today had a lot of patients in them or a lot of information to track. The second thing I want to say is just because you're critically appraising something does not mean you're rejecting it. Okay, I'll say that again. Just because you appraise something's statistical merit doesn't mean that you're going to either throw it away or keep it. The third thing that I want to say is that my overall theme is going to focus on the outcomes. And another word for that when you talk about critical appraisal is the classification of disease or the misclassification of disease. That being said, this is a very, very difficult study to critique, I think, from a methodology standpoint. And the important thing is, I think that in order to determine whether or not someone had kidney stones, the gold standard was not CAT scan. The gold standard was people were called and asked, did you have a urologic procedure or have you peed a kidney stone? Okay, so that's pretty intense that you had to either pee a stone or have it removed surgically to determine whether or not you had kidney stones. Okay, so I'm gonna blow everyone's mind. The CAT scan may be wrong. You might have calcifications next to the ureter in patients who you think have kidney stones that might be misclassified. And that's why the sensitivity and specificity from this particular study for renal ultrasound and kidney stone is, it's quite encouraging because it's pretty high. It's similar to CAT scan. Now, when I first read that, I thought to myself, how could that be? I mean, I really believe CAT scan is the end all be all. And the truth is, it probably takes a radiologist to say that statement, what I just said, which was that the classification, that calcifications next to the ureter in patients that have a history suggestive of a kidney stone may just be calcifications and not a kidney stone. I don't think ER doctors get away with saying that. Only someone as sophisticated as Dr. Smith-Blindman, who's a radiologist, I think can say that. And if you guys really want to dig and have fun, you can read what the editorial letters are in the New England Journal of Medicine to this study, and she addresses that directly. And she kind of addresses it here, where she says specificity was lower in the prior research because we used a stringent reference standard of stone diagnosis, okay? So outcomes matter. That's my theme for today. Unfortunately, when you think about the outcomes, it's also how that impacts your study is very subtle and can be confusing. So bear with me as we go through all these studies. But that's my theme today, is consider the outcomes.
All right.
Oh, I did want to mention one thing. I'm sorry, I forgot to mention one thing, which, sorry to come in late. There is a possible bias in this, which is incorporation bias. Incorporation bias is when you use the index test, in this case it would be ultrasound, CAT scan, whatever, to determine what your follow-up is, your ultimate classification of disease. Now, in this case, I think the patients were told of their diagnosis. We all taken care of kidney stone patients. Some of them can be quite neurotic. When you tell someone, oh, you have a 12 millimeter stone in your ureter, my suspicion is that they're probably going to be being like, oh my God, did I pee it yet? Oh my God, did I pee it yet? You know, or oh, did I get the, is there sediment? Or they might be more likely to go to the urologist, who's probably more likely to remove a stone, as opposed to someone who has like a 3 millimeter stone that gave them symptoms, but then resolved spontaneously. Okay, when you have that condition, you may falsely increase your sensitivity. So perhaps all the modalities have a falsely increased sensitivity. Okay.
All right. Well, if you can do that with an impact factor 59.5, let's see what you can do with this. So this is the Stone Plus study. So the Stone score, in addition to the ultrasound, the methods for this was a prospective observational study of patients who were going to get a CT for suspected renal colic, adult patients at 2 sites, an academic site and then a freestanding ED, again, about a 1.5 year period of time. The interventions that all of the participants had were a stone score, we'll go over what that is, a point hair ultrasound, and then they had a CT for stones. Outcomes were symptomatic stone, any alternative findings that they found on the CT, and then need for urologic intervention. They followed them out to 90 days. And ultimately, the goal was to decrease unnecessary imaging related radiation. And so keep in mind that when we talk about some of the outcomes, that was their primary outcome, was to see if they could decrease radiation. This is the patients that they had that ultimately were, I think, 2,000 or so folks that they initially thought they could enroll, ultimately got to 1,000 that were possible. And then the subjects were a little over 800 that either got the had symptomatic stone or non-symptomatic stone. Here's some of the data and important points I think to bring out. Again, in this group, 38%, which is similar to what we saw before, had a history of stones. I thought a very important part of this study was that a good portion of the patients, almost 30%, 28%, almost 30, had duration of symptoms that were less than 6 hours. Keep that in mind as we move forward. And then their stone scores, up to almost 83% of them had either a moderate or high stone score going into this. So again, high probability of having it if you believe the stone score. And here is the stone score if you're not familiar with it. Has to do with sex, timing, race, nausea, and then whether they have red cells in their urine. And then if you look at the ultrasound results, found that they didn't have enough patients that either had severe and moderate. So they just combined those two. So you either had any hydronephrosis or moderate or severe. If you compare that to the stone score, where you had almost 83% were a high pre-suspicion of stone, you see there's a little bit of a discordance there, and you have to wonder why that is. The other thing I thought was interesting is only 0.2% of their patients eloped. I'm not sure if it has external validity because that's not my patient population at all. I have a much higher elopement rate. But anyway, I'm sure you'll talk about that as the study. It appears to me that animals must have been trying to save on their costs because poor Chris got a grayscale chart here. So I'll add some color to it. So any hydronephrosis is going to be represented in yellow, and then moderate or severe hydro is going to be in blue. And they basically presented all of their data in this chart, and it can be confusing if you look at it initially. So the y-axis is actually the percentage of patients that had a symptomatic stone. On the x-axis is actually their stone score, so low, moderate, or high. And then the columns represent on the far left is going to be just the stone score itself, and then on the right is going to be whether they had no hydro or any hydro. So if you look at what the ultrasound added to with any hydronephrosis, it increased their chance of finding a stone or increased the incidence of stone actually fairly significantly. And if you look at their moderate or severe, it increased it quite a bit in the low stone score group. If you look at the moderate stone score, wasn't nearly as impressive, but yet it still added to the clinical stone score, and then moderate or severe, again, significantly added to it. But then if you go to the high stone score, you see that ultrasound really didn't add that much to it. You already knew that they've got it, their incidence of stone was high, and so there really wasn't that much additional benefit there. And so the conclusions of this study are that point-of-care ultrasound is most helpful in the low to moderate clinical likelihood according to the stone score. Again, not necessarily how you or I would think of it, but how the stone score would classify it. And then the ultrasound findings in that high likelihood group had little impact at all, other than the increased need for urologic procedures. And I think that's a caveat that we should consider when we interpret this data. And so then they devise an algorithm that may help actually reduce CT use and radiation exposure. And again, black and white or gray, cutting costs apparently. So I'll go ahead and color it for you. So in the low stone score, if they had no hydro, they think either they don't have a stone or you should pursue a different diagnosis. In the group that's either moderate or low, but if they have some hydro, whether it be any or moderate, then those are the folks that they suggest that you should get a CT scan, but it should be the low radiation type of CT. So that may, if you feel like you need to classify the stone further. And then those that are in the high likelihood group who have any evidence of hydro, or in the moderate who have moderate to severe, those are ones that you could potentially manage presumptively if you need to know where the stone is. So the limitations, I think, are the study is conducted in an academic medical center. There's a wide range of ultrasound experience that they don't classify that in this study, so we're not sure who was actually doing this. And the patients were enrolled because they were getting a CT scan. And there's a lot of folks I think we know in this day and age who I don't necessarily get a CT scan. And so these are folks that we knew were going to get imaging for some reason or another. And then I think the fact that 28% of the patients had symptoms less than 6 hours, and if you think of the natural progression of stone disease, that maybe they weren't going to develop hydro, they may have selected a group on purpose or artificially that didn't have hydro. So Dan. can ultrasound be used for clinical decision making? And again, keep in mind, you're going to be critiquing the folks from Yale, and you're only from Wash U. So, keep that in mind. In my mind, the equivalency. So.
Yeah, exactly. Okay, so this, I think, there's a lot of things going on in this study. I don't have time to break down everything, but so does ultrasound compare to CT? I actually think yes, but it wasn't necessarily answered here in this study because this study didn't use stringent classification, as stringent a classification as the first study. In this study, the follow-up was either was chart review of urologic notation. There was no telephone follow-up. So just keep that in the back of your mind. But I wanted to illustrate something else, also which you alluded to, which is that why isn't ultrasound doing more for the people who appear at high risk? Okay, in other words, the people that are like sitting there with the stone, when you look at the results, it looks like, oh wow, and just look at the boxes, okay? And by the way, I'm not focusing on the CAT scan. I already mentioned, I think that the first results when they use CAT scan to as their gold standard, as their classification, I think those results, you have to interpret them with a bit of caution based on what I told you after the first study. The second study, what I thought was interesting is that this illustrates the concept of spectrum bias. Spectrum bias means that some diseases, the intensity of disease will sometimes influence how well the test performs. Okay, so in other words, let's just take cardiac cath. If you have someone who has a 98% lesion and you're gonna go do a cath on them for CAD and it's 98%, okay, that's easy. Yes, this is what's giving them their chest pain. But if they have a 71% lesion, remember 70% is the cutoff, what then? Do they really have CAD because of 1%? Well, what about if they have a 69% lesion? Do they not have CAD? So that concept is spectrum. The intensity of the disease will sometimes drive what your test characteristics are. Okay, that being said, in general, your sensitivity should increase when the intensity of disease increases. And in this, which is the performance of stone compared to urologic follow-up, if you look at the first box, the sensitivity for any hydro is 66%, and the sensitivity for in the high group jumps up to 81%. Okay, and I'm guessing that the patients who have a high stone score are sitting there writhing in pain, maybe because they have a bigger stone or they're having more hematuria. Does everybody see that? So the intensity of the disease is increasing, and the test characteristics are getting better. Okay. The other thing that will happen is your specificity will go down, and the same thing happens here. If you look at the second, the column there, the specificity of 58 goes down to 39%, and the specificity of 86 goes down to 79%. And this is the effect of spectrum of the disease. So as the disease becomes more intense, it's easier to characterize the true positives, and your false negatives become also easier to classify because there's not too many gray zone patients. So box C, if you remember ABCD on your 2x2, which is actually a very complex thing. It seems so easy, but it's not. That tends to grow. So this study, I think, illustrated the concept of spectrum bias. The other thing that this may illustrate is another concept which has to do with independence of tests. Okay, when you have two tests back to back, in general, they tend to be related. So when the first test is positive, the second test tends to be also positive. Okay, if the first test is negative, the second test tends to be also negative. That's just a fact of life. Like think, for example, if you were doing cyanosis for pneumonia and you were comparing your physical exam finding of cyanosis to a pulse ox. Okay, the cyanosis and a low pulse ox are related, right? People who are blue are going to have a low pulse ox. Fair to say? Does that make sense? Okay, so another explanation for why your sensitivity goes up as your spectrum of disease becomes more intense is this concept of non-independence. When tests are considered independent, but are actually non-independent, like the cyanosis and the hypoxic degree, you get this funny effect where your sensitivity goes up and your specificity goes down, okay? So what I will hypothesize here is that the first test is the Stone Plus score or the physical exam. If you look at the Stone scoring system, as you get higher, you tend to have more nausea, more vomiting, more blood in your urine, okay? And that usually is associated with our more severe cases of kidney stones. So of course, those patients tend to have their diagnosis more readily made compared to someone with a low stone score. The whole point of this talk that I just made up there is to begin your confusion about the independence and non-independence of tests, because it's very subtle. But remember I said the emphasis is on outcomes and how you classify things. Now you have to start to begin to critically appraise this literature. You have to start thinking, well, how does my index test relate to how I'm classifying who has disease, okay? And this is tricky here, even though I'm saying that my index test is an ultrasound, is there something else going on? Like for example, the physical exam, okay? Because you are usually seeing the patient that you're doing your ultrasound on and then doing research on. So in the perfect world, you don't see the patient that you're doing your ultrasound on. It's the perfect research world. But in reality, that doesn't happen. You actually get to know what your patient at least looks like, okay? And when they're writhing in pain, clutching their side, that is a subconscious or conscious cue that this guy probably has a kidney stone. You're gonna be more likely to call hydro. Okay, so spectrum and independence and non-independence of tests is what this kind of illustrates.
I did like the idea, though, that a low stone score, that hydro really did significantly.
Yes.
That ultrasound did help in the low one. So it may not help as much in the folks that you can say, yeah, that's a stone. Anybody could figure it, but in a low it might. Okay.
John, before you move on, that spectrum bias that actually Dan is explaining right now, it's not necessarily is a bad thing. It's the thing that we are using it. And all the time when you talk to biases, it's come to my mind is a limitation of anything that you use. You use that all the time for the fast. You say the fast for any fluid in the belly is go 70%. But the patient that need to go to OR is rise up to the 90%. That's a spectrum bias, but we are using, this is actual, the use of that, independent use of that actually the test. The same thing for appendicitis. We say early appendicitis, sensitivity is 60%. When you have more than 21 hours, that the study that came out like 2 months ago, 21 hours after onset of symptom, sensitivity is rising up more than 89% for this appendicitis. So the spectrum bias, because we don't have another name for it, we can still call it bias, but this really function of the independent function of the ultrasound.
All right, so the third study is was going to assess, does it matter who does the study? And so provider experience. So this study was a prospective observational study of patients coming in with renal colic in patients greater than the age of 18, year-and-a-half period. Bedside ultrasound was done to assess for hydro, none, mild, moderate, or severe, and then CT confirmation in all of them. And what they were really looking for was how do physicians at various levels of experience do in terms of their assessment of hydronephrosis. This is the data that they had. You can see there were 679 folks that were initially enrolled. Those that had hydro present, about half, 48%, and then those without hydro. And then if you look at the ones that were the true positives were 231, and the true negatives were 94. The false, absent, present, so false positives, and then false negatives are here. So I love these graphs. So here's provider experience. So this is the inexperienced clinician, and it's color-coded. You probably have seen these: true positive, true negative, false positive, false negative. You never want to be the person that's all red, like the people in the top there, you can tell. And here's the experienced residents. Again, a little bit colorful there. And then this is the attending stuff as well. And again, you can look up some of the upper attendings there. Someone they were false negative the whole time. They clearly didn't know what hydro was or couldn't see it. Anyway, and then attendings with fellowship training were the bottom line. So this is the data in table form. And I just want to highlight some of the findings. So there's sensitivity specificity for everyone. Just looking at hydro was 72%, 73. But if you go down and look at the attendings with fellow training, much higher, and with a positive likelihood or positive predictive value of 4.97. Now, if you look at just moderate or severe, for everyone, 31 was the specificities, sensitivity specificity 94, positive likelihood ratio 5.76. But now if you go down to the folks that had fellowship training, significantly better. And that's ultimately what they conclude in this study. But they also go down and they talk a little bit about the incorporation bias of the folks who were actually doing the study and whether it actually did increase it. And it did some, but it wasn't dramatic when it comes down to this. So the conclusions, limitations here, ultrasound is moderately sensitive and specific for hydro. Those that are fellowship trained are much more definitive in their studies. But in this particular study, there was no data regarding the timing of the ultrasound relative to the onset of symptoms like we had in previous studies. And we really don't know the information about their ultrasound experience. So even though they used 2 weeks of an ultrasound elective, we don't know how many studies the person that had all of those false negatives actually had done previously. Those may have been the first 3 studies that they ever did on a renal ultrasound. So Dan, does it really matter who performs this study?
So the short answer is yes, obviously. The point that I want to illustrate, remember, is I want to focus on how you classify outcomes. In this paper, this illustrates the imperfect gold standard, what some people refer to as the copper standard. So what does that mean? That means, what if your test that's going to tell you to classify whether you have disease or not is worse at doing that than the test that you are doing research on, the test that you're testing, okay? So to put yourself into that mindset, I want everyone to get in their time machine and go backwards, probably to the late 60s, early 70s, and when CT starts coming around, and imagine a test where they wanted to examine the use of CAT scan for pneumothorax, but the gold standard was chest x-ray. Okay, so now the gold standard is chest x-ray, and you're doing a CT of the lungs to determine whether or not there is a pneumothorax. Okay, so I think now, if you can fast forward, we all know CAT scan's way better than chest x-ray, but what would happen to those test characteristics in CT back in the 70s if they used chest x-ray as their gold standard? And in the interest of time, I'm going to just let that linger for a little bit, and then I have a graphical representation of what that of how that all tends to play in. Okay, so basically, the long and short of it is that your sensitivity and your specificity of your gold standard is actually worse than the test that you are actually trying to examine or to do research in. Okay. Now, just to close, I actually do think that you can use ultrasound in these renal stone cases. I think that experience does matter, obviously. And I do think that that first study illustrated some important points, not so much for ultrasound, but of CAT scan, because I always thought that the sensitivity and specificity of CAT scan would be like at 100%, and it was not. When it comes down, it actually comes down to something maybe a little bit better, but not that much better than ultrasound. So that's how I use the bias. That's how I interpreted the biases in all these studies. I'm sure pretty soon we're going to get a meta-analysis with all the data from the people at Yale who did tremendous work in order to get this data up there. And you can see that there is a tiny range of sensitivities and specificities, but remember to always ask yourself, how did they end up classifying disease, and was it the same across studies? Okay, if all the data that you presented get pulled into that RCT, the answer is no, not exactly. Things are slightly different. And could that explain why we have in the 2 studies from Yale slightly worse sensitivities and specificities in some cases?
Thanks, John and Dan. So next 2 articles that I'm going to just talk about. This first one is going to be, we don't have topic. Okay, first I'm talking about the topic of the pneumonia. Actually, we picked 1 article for the pediatrics, and 1 topic is in the adult pneumonia cases. The first article is the article that from the very well-known author that you guys see. I put this Dr. Jones picture over there. not to just contrast Jim, but just want to make sure that that's not Alan John. And so this is replacing actually chest X-ray with the ultrasound. That's the question of the randomized control trial in chest. So it's been done is the Mount Sinai. And it's a randomized control trial. It started in August 2012 until July 2013. And they actually, what they did, 191 cases that they are coming to the PEDS ED, they actually randomized to get the chest X-ray or ultrasound. It's 2 lines of this, actually 2 arms for the randomized control trial. And the ones that they got the X-ray at the beginning, all of them, they got the ultrasound subsequently again. And they got the ones that they get the sonogram all at the first time. So about 60% of them later on got the X-ray again. So a 15 PEM ultrasound, actually faculty and fellow, they did it. They did a 6-zone. I don't want to go in detail. They showed some of the pictures, some videos that we are not going to talk. One thing I want to mention in this picture, if you see there is they call that sub-centimeter long consolidation, and that definition is the majority of the cases that discrepancies come from ultrasound and the X-ray. This is in the top right side. You can see that sub-centimeter long consolidation. Normally, you don't see that in X-ray. Is that clinically important? I don't know. Is that the part of reason that is actually in this study, they have the higher rate of the antibiotic to start? I don't know. I can't, that's Dan is going to explain that one. But this is not about the diagnosis of the pneumonia with ultrasound. Really, the only thing is just try to see how we can impact utilization of the X-ray for this group of the high-risk patient that they are coming here. So they found that they have 39%, about 40% of the reduction of the X-ray in the line that they use ultrasound. What happened to that 60% is about 38%, actually they asked, the 28% being asked to get the X-ray again because the parents wanted or the admitting doctor wanted or somebody else wanted. They didn't want it for the clinical reason, for even non-clinical reason they have it. So if you can see, the thing that is actually, I think is interesting to realize, you see that the confirmed pneumonia in X-ray is only 13%. Is that a right population that we did a study among them? We have 13% out of 100% of these cases, they are getting X-ray, positive in the X-ray. And that is pretty equal in 2 groups. We have 10% later on, you can see that actually 28% in the ultrasound, that 10% is come from the sub-centimeter, actually the consolidation that they have. The conclusion that they have the long ultrasound can replace safely for the actually with chest X-ray. What is the gold standard for this, for ultrasound and for X-ray? We still don't know. But when I just actually look into the online document they have, it seems that actually for a majority of these cases, they follow their cases. They call the patient now. I think that's the reason this article ended up being in chest even. Part of that because they called up on this, a lot of these patients is coming back or they got the pneumonia later or get the antibiotic or not. So these, to just steal from Dan some of the thought, I think in my perspective, this great the article, the few things that is important, one, overutilization. We are doing more testing, we find more stuff that is clinically not relevant, and then we started more antibiotic for this patient. It's clearly actually straightforward in this, or you want to support, you want to cover yourself. You just started doing sono, you're not 100%, you see something, say at least I'm going to start you on antibiotic anyway. So that's probably, that's very important. And the second thing, not having a gold standard for this one. And I want to ask Dan to actually see if it's mission accomplished so we can replace.
You're stealing my computer. Okay, so outcomes matter, right? Come on, it's DC, right? So if you think about this picture, I mean, this is sort of misclassification bias, right? Because on this very day, everyone was like, woo, we did what we said we were gonna do. And then you move like years later and it's like, it didn't quite turn out that way, right? So again, the way you classify your gold standard in this case, which was the press conference a few days after the invasion or whatever you want to call it, compared to a press conference now given 15 years later, would give us very different answers. Does everybody pretty much agree on that? Okay, so outcomes matter. I thought this particular study was, Is anybody here from the group that did this? So they're probably watching me. Oh, okay. Well, I wondered, internally, I'm a decision editor at AEM, and I was wondering if perhaps this one got sort of over-edited in the whole process, because this is an RCT and they're trying to look at decreased utilization. And in the ultrasound arm, in the intervention, which is lung ultrasound, then chest x-ray, you're allowed to skip the chest x-ray. But in the control arm, you're not allowed to skip the chest x-ray. Everybody had to have a chest x-ray unless they left without being seen. And unlike your shop, I guess their shop had no kid left without being seen. So they all got chest x-rays. So that's really got nothing to do with diagnostics. It's got everything to do with that their outcome was, I think, potentially artificially increased. If you actually dig into this thing though, you kind of end up with this chart, which is more of the diagnostics. And it goes back to imperfect gold standard. If I actually spent some time last night trying to come up with the gold standard for the diagnosis of pneumonia, and I went back into like the PORT study, which was like this huge, again, New England, I think JAMA published that one. And there is no gold standard. So whenever you see pneumonia, the first question you have to say is, well, how did you diagnose that pneumonia? Because the big studies use ICD-9 classification. And if you've done research with administrative data, you know a lot of that is just, well, God knows what it's saying, really, what really happened. And especially in children who get viral pneumonias or just wheezing or asthma, the spectrum of disease there can be so heterogeneous, so different, that if you misclassify pneumonia, you can get all kinds of different results with your index study. Okay, so again, using an imperfect gold standard tends to decrease your sensitivity and increase your specificity. And that's what happened here. If you look at the top red box, these are the cases where your chest x-ray, if it was equivocal, was considered negative. Okay, your gold standard was sort of considered negative, and you get this really nice sensitivity and pretty good specificity. Now your gold standard is, in the bottom red box, is considered positive, and look at what happens. Your sensitivity drops and your specificity increases. So that is the effect of using a test to classify disease that in this case may be worse than the test that you're doing the research on, than your index test. So, and I thought these results were kind of pretty intriguing. So this was not, this is in their supplement. So if you go into this, that's what you can find. The other thing that's, I think, important, I think you alluded to this, is if you go into a pediatric ER and you're told that your child does not have pneumonia, and you're not given antibiotics, and if you don't get the x-ray, I have a sense that you are biased if your kid's not doing better 3 or 4 days later to go to the doctor again, compared to a kid who came in, got a chest x-ray and antibiotics. And even though it's not doing better, the parents think, oh, but he's getting treated, so he'll probably do better in 10 or 12 more days. Okay, and that misclassifies a lot for this study, because I think some people went to are more likely to go to their doctor, which was one of their primary outcomes, because of the way they were treated, not necessarily the way they were diagnosed. Okay, so subtle things here. Some have to do with diagnostic biases, some don't. But I thought that the illustration of an imperfect gold standard here was kind of interesting, because chest x-ray is imperfect.
Okay, so we have only 10 minutes left, and I have 4 articles. So I just want to yeah. So for the next one, I'm going to just tell you what the topic is and just issue one slide for the result. So the second one is the adult and pneumonia, and it's a meta-analysis that came out just recently. And it's just like the largest meta-analysis of pneumonia in adults, and they have 2,359 cases. It's pretty strong, actually, methodology they used. And I don't want to go through all this stuff. I want to just show you the gold standard, they are using the high quality for the CT one. The ones that the chest X-ray is the low quality. That's the definition of the quality of a study they did. And this is the result that you are seeing here. They have the rock curve analysis that they see is a 0.93. It's pretty strong, actually. One of them is the strongest that we have that Dan is going to just talk about this. And they try to find out is actually the high and low quality try to find is the rock different between it's kind of adjusted actually the transform the false positive rate they are reporting in here. And they still feel there is no difference in terms of the quality of a study, in terms of the reference standard. I mean, you're doing a chest X-ray or CT, in terms of the flow of patient, none of them is simply affecting the result of this study. So it's pretty strong looks coming here. But I want to just like that, you know, the discussion after that is coming up from the New England Journal of Medicine and Journal Watch. That was the actual comment is coming. Accuracy was not good enough. It's 90%. They said not good enough to replace chest X-ray, but lung ultrasound might be helpful. And immediately one of the ERs people, they are responding. They said, so you're referring to actually chest X-ray that has 43% compared to a 90% CT scan sensitivity. So I want to ask to clarify that. Actually, Dan is going to clarify pretty fast, hopefully.
Was that a hint? Okay, so this is a meta-analysis on diagnostic tests, okay? And this is the key slide here. I think it shows a couple things. Number one, this is an ROC curve. So the better tests should be if you're facing it the upper left, okay? That's, if your test lands in the upper left, like all those triangles do, then you, that means that lung ultrasound is very good at diagnosing pneumonia, okay? Now, the other thing you have to know is that every triangle up there was judged a poor quality study. And look at where the triangles sort of tend to float. They tend to float in that upper left-hand corner, okay? Except for one, that little green dot. Does everybody see the green dot? Okay, that's kind of up there in that upper left. And it's a high quality study because everybody got a CAT scan on that study for pneumonia. So there may have been some spectrum bias, fine. I think that this slide is really a graph for the requirement that we do a high quality randomized controlled trial for diagnosing pneumonia with ultrasound. Because in my book, there are 3 images associated with being a doctor: white coat, beeper, and stethoscope. And this study here is saying that we may be throwing away our stethoscope because lung ultrasound can perform pretty darn well for the diagnosis of pneumonia. So I wish Jeremy Brown, I think is his name, from the NIH were here to see this slide, because I think it's a call to all of us to do a large randomized controlled trial on the diagnosis of pneumonia using ultrasound. And I'll just end there.
Well, it looks like I've got 6 minutes, so we'll 7, we can 7 or 8.
I took 10 minutes off.
Yeah, we started a bit late. That's fine.
right,
Thank
right.
you, Dr. Boniface.
So the topic of pelvic ultrasound. First, we got to quickly just some core references. I'm not going to go over these, but I had sort of included these, and I was glad I did after the discussion yesterday. People were talking about endovaginal ultrasound and difficulties you have in your institution, maybe doing them, talking to radiology about it, OB about it. So put these in your back pocket to know. The first, a meta-analysis looking at all these studies for diagnostic characteristics for ED point-of-care ultrasound, showing that we are good at what we do. And then the question came up yesterday about, well, what if I have 24-hour ultrasound available from radiology? Why would I bother doing it? And I think Nova answers this question brilliantly in the study from a couple years ago, where they said it's all about the times. Even when patients can go to radiology for it, if they get these studies from point of care from the ED, they get out of the ED much faster. And so take a look at those. That's all I'm going to say about them, but use those when you, if you do have to have some of those arguments and discussions with people. I want to introduce the idea, what was an introduction sort of for me as I started looking at this. of what other features can we look at by pelvic ultrasound for the diagnosis of ectopic pregnancy. You know, we're looking for IUP, presence of IUP, or clear evidence of ectopic in the adnexa. If we have an empty uterus, you know, we're dealing with an early IUP, maybe a spontaneous AB or an ectopic. Is there any, in addition to just looking for gestational sac, yolk sac, fetal pole, these things, is there anything we can say about the sonographic appearance of the endometrium to say this is more likely in that empty uterus? What does the endometrium look like, and does that predict ectopic? So we can look at the endometrial thickness, and we can also look at the echogenic pattern of the endometrium. And these studies are going to show, classify these into 4 categories. There's homogeneous hyperechoic, and then heterogeneous hyperechoic, a trilaminar pattern, and then interluminal fluid or pseudogestational sac. And this is from one of the studies that sort of gives examples of these. In the upper left-hand corner there, that's that trilaminar pattern, and you'll see this referenced in a couple of studies we'll talk about. What you have is sort of hyperechoic lines sort of in the borders of the endometrium, and then a thin hyperechoic line in the center, and that gives you those 3 lines, that trilaminar pattern. And they're also just demonstrating the measuring the thickness of it. To its right, in the upper right-hand corner, that's our homogeneous hyperechoic endometrium. Lower left is the heterogeneous hyperechoic, and then interluminal fluid or a pseudogestational sac there in the right lower. So we'll get into these studies. These are 2 studies I've got that sort of investigate this idea of endometrial appearance. I will say that there are many more out there, and there's a variety of results. Most of the studies show that it doesn't really work all that well, or it's certainly not something you're going to hang your hat on. The studies I've chosen report strong results, and I'm going to leave it to Dan to rip them apart and show why maybe they're not, you know, you should, even though they report that it works well, maybe we should think twice about it. This first study was actually a retrospective review. They've got patients who were pregnant that had abdominal pain, a suspicion of ectopic, no evidence of IUP, and no evidence of ectopic either, you know, when scanning of the adnexa. And this is either done by the ED or, and then even radiology ultrasound. Final diagnosis of ectopic is made by a chart review. And then they look at all these patients and measure the things we're talking about, endometrial pattern and the thickness. They had 403 patients, 64% of those turned out to be ectopic. They focused on this trilaminar pattern that I showed there. 98 out of the 107 patients that had that trilaminar pattern had an ectopic. So 92%, you got that trilaminar pattern, 92% of those patients actually turned out to have an ectopic. Look at it the other way around, what percentage of patients with an ectopic had that trilaminar pattern? Much lower, so it's 38%. So they reported 94% specificity and 38% sensitivity. They looked at endometrial thickness, and the general idea here is that in an IUP, the endometrium is going to be thicker because of the proliferation that's going on there, and an ectopic that'll be thinner. And that's what they found is that average for ectopics was 9.5 millimeters. And then in the IUP variants, more in the range of 12.5 millimeters. But they couldn't identify an ideal cutoff for endometrial thickness to say this is below this is ectopic and above that is IUP. And rip it apart.
So I want to introduce the concept, or reintroduce to the concept of a double gold standard bias again. Now, a lot of you guys have heard me talk about this for a long time. Remember, I said the focus is on outcomes and how you assess those outcomes. Well, sometimes not everyone gets the same assessment of the outcome because it's unethical to do so, right? Not everybody who you're ruling in or out for appendicitis can go to the OR. And this study is subject to that because not everyone is going to go for a DNC. Some women are going to have follow-up of their betas sequentially, and other ones are actually going to have a DNC or even a laparotomy in this case. So I just wanted to show this graphically. I will say that in general, this kind of stuff is best for small group sessions. And I have nothing to do with this course, but there's a course out of UCSF, which I recommend all of you because you get to do this and really play with the numbers, and only then you really grasp it. And you tend to have to go back to it. So this is my first this is my baseline. Okay, it's a test with 90% sensitivity, 90% sensitivity. Pointer here, pointer. Well, anyway, in the top left, the top left 900 are your true positives. Okay. Okay. He's not playing with me right now. Oh.
We shop at the same store.
Yeah, I know. Right? So the 900 are your true positives, right? So people classified as having disease, and by your index test, and also the gold standard. Thanks. Okay. So that's this 900 here, okay? And in this, I made this up, by the way. So you have true positives, 900. You have false negatives, 100. That gives you a sensitivity of 90%. Here you have false positives, and I'm sorry, false negatives and true negatives. Did I say that wrong? Your sensitivity is 90%. Yes, false negatives, true positives. Okay, so that's your 2x2 table in theory. Okay, when you have double gold standard, one thing really happens, which is your box down here goes to this box. So people who in reality have the disease, but because the disease spontaneously resolves in some cases, so like an ectopic can reabsorb and no intervention, no methotrexate, no surgery is needed. Okay, that kind of blows a lot of people's minds, and it did the same thing to me. But if you actually read the OB literature, in some countries, expectant management of suspected ectopic pregnancies is actually performed. And so we know that some women just, the ectopic goes away and they don't bleed. Not all ectopics are created equal. Some bleed and have to go to the OR, some resorb. And that's an important concept because when you're setting up your research study, you have to ask yourself, is the disease process that I'm going to research, is the natural disease, is the natural course allow for some of the cases to just get better on their own, okay, without any intervention? And if the answer is yes, then you're going to have, and you're also using two different ways to assess whether or not someone has disease, you're going to end up with this bias, which is double gold standard bias. And basically what happens is that the people in this who have the disease present but have an index test that is negative get misclassified to true negatives, okay? And then when you do this, if you play with the boxes, your sensitivity goes up and so does your specificity. Your sensitivity tends to go up more than your specificity, okay? So in all of these studies that we're gonna talk about, they actually had not good sensitivities and they were biased by double gold standard. So to me, what that means is, wow, you know, you set yourself up to succeed and you still failed, you probably don't have a good test. And you know what? That would have been a great conclusion, right? Oh, the trilaminar test is not sufficient to diagnose ectopics, right? I would have been really happy. Then we would have stopped studying it and moved on to, who knows, a biomarker, another ultrasound marker, contrast in ectopics, who knows?
So in the same vein, a second study, this is done, published in the International Journal of Gynecology and Obstetrics, study done in India. And you'll see there's been a lot of differences in this study in terms of the standard management of these patients. And Dan, we'll talk about that. But what they were looking at were patients with that were pregnant without an identified location or by ultrasound of the pregnancy. They looked again at endometrial appearance and the thickness. Here's one of the big differences. All these patients that presented to the hospital who were pregnant, and this had nothing to do with the complaints of abdominal pain, vaginal bleeding, they just show up and they're pregnant. If they could not identify the location of that pregnancy, all of those patients were admitted to the hospital for observation to make sure that they did have an IUP. Patients had a repeat ultrasound and a repeat quant, at 48 hours. And then they looked at rise or lack of rise in the HCG. Patients that had greater than 66% rise in HCG were followed for emerging evidence of IUP by ultrasound. Any patient that had less than 66% rise in HCG went to DNC. Actually, they got an ultrasound first to make sure there was no IUP. And then every one of those patients that had insignificant rise in their HCG went on for DNC. And then they did histology to examine for chorionic villi. If they had that, they were classified as failed IUP. If they did not, they were classified as sort of failed ectopic. They had a total of 100 patients. 45 of those patients had no adnexal signs of ectopic. And of those, ended up with 21 were normal IUPs, 10 ended up classified as failing IUP, and then 14 of them had ectopics, for a total of actually 69 ectopics, because you've got the other 55 patients that had adnexal signs of ectopic. They included those patients as well. All the patients that clearly had an ectopic by ultrasound, that's 55, and the 14 that had ectopic by their other confirmed by DNC, and a total of 69. They were looking at what the endometrium looked like. Patients that had a heterogeneous hyperechoic endometrium, that finding was 76% sensitive for ectopic pregnancy. And then the trilaminar sign that we talked about earlier, that was 80% specific for ectopic pregnancy. You take any of those, kind of lump those together and say, if we consider normal IUPs should have this homogeneous hyperechoic appearance to them. So let's lump the things that don't fit that category, take the heterogeneous hyperechoic and the trilaminar sign, put those together, and we'll call those the non-homogeneous hyperechoic pattern. That's 90, then they report 95.7% sensitivity for ectopic. And we look at the thickness, same idea, where it's thinner in ectopics and thicker in the IUP groups, 8 versus 11. They did come up with a cutoff of 9.8 millimeters with an ROC curve. And now Dan will love is combining these two tests. We just say, let's combine our non-homogeneous hyperechoic categories with the thickness cutoff. Then we combine those. Now we have 100% sensitivity for ectopic pregnancy and a negative predictive value of 100% and positive predictive value of 86.4%. We take those two criteria together.
And Dave, over breakfast, I told you you can't do that.
What?
Because you can't combine tests, right? Because they're not non-independent. Okay, this is my last slide. I want to conclude because in my opinion, this test had all the biases. This research study had all the biases in place. And you know what? They still got a crappy answer, right? If you disregard the 90% sensitivity and all that, if you just look at the endometrial analysis, it just didn't work, okay? And yet they still conclude, or they found a way to say, hey, this might work. It's like, no, just conclude that it does not work. So what were the biases? Well, I kind of tried to outline it in this slide. So the first red box is, I think that they had a bit of a incorporation bias. See where it says TVS? That's incorporation bias, because they actually used ultrasound to determine what they were going to do, what the final classification of the patient was. Now, Dave appropriately pointed out that you can see that the yes n equals 0, so it didn't seem to make a difference, but I believe that it probably affected your specificity. And I'm not going to go into the math. The second thing, double gold standard bias, right? All these tests have it because you're not going to do a DNC on all your patients. You're not going to take all your patients to the OR. When you do that and you have a condition like ectopic pregnancies that can spontaneously get better, your sensitivity and your specificity are falsely elevated, okay? The sensitivity and specificity were pretty poor, even though we were biased to make them look good. And then my last point is that there's imperfect gold standard. So Follow-up may not be the same as getting a DNC, or a DNC might not be the same as getting a laparotomy. All of those, the way that relates to your study will cause your sensitivity and your specificity to look better instead of worse. And still, the primary outcome, which was the sensitivity of this trilaminar finding, was really poor. So I think that it is a useless test, and I would stop studying it personally, but I'll allow people to keep studying it if they want to. And I'll also say that I think probabilistic and logical thinking is probably very difficult to do at 8 o'clock in the morning. This is stuff that you should probably do, I'd say around 1 o'clock, probably some martinis in you. And then all of a sudden this stuff does make more sense. But just so you guys know, just to do the lecture and to put these things into words, I have to make 2x2 tables, and I have to read and reread the biases and see how they would play. It's very difficult to do. And so if you're confused, don't feel bad. It just requires a little bit more review. And Teresa Wu, I'm looking at you because Teresa's heard me talk about this twice now. And I finally said, how should I make this lecture better? And she said, tell me what the take-home point is if you're doing research. And the take-home point is, if you're doing research, you have to make it a research study. This, I think, is just what the standard of care is at this hospital. And then they obtained sensitivity and specificity of where they're at different points of their workup, and they tried to publish it. But that's not the same as doing research. In research, whether or not you believe someone has the disease forces them to have the gold standard. And that gold standard should be 1 or maybe 2 acceptable things. Okay, you can't wiggle out of that. And what's happened in this particular study is that some people went right to the OR, other people had follow-up, other people had a DNC, other people were just discharged and presumed not to have ectopics. All those things bias your tests and make it look better than it actually is. So when your result is that it's not that good, you should just say, I don't think this test is that good. And with that, I'm going to conclude.
Great, thank you very much. Thank you for your attention, and I want to thank John, Dan, and David. Dan, he's been all night, been actually writing all this the lecture. If you continue, probably get bloodier and bloodier. So we can conclude right now. Thank you very, very much. It's a great discussion.
All right. Thanks, and I appreciate it. I know it's a lot to cram in, and we had a couple extra minutes for Pointergate, so I think we'll bring down our next panel. It's going to take a couple minutes to set us up. We have an international guest that we're going to bring on if technology allows us, and so we'll have our next panel come on down. We have down the hall, around the corner, if you go all the way down to the end of the hall past the bathrooms, for the fellows, we have a great breakout session set up with our HeartWorks TEE simulator. Cameron Baston is down there and is going to help us out, filling in at last second for Mike Livis. Thanks, Cameron. So, try to root through your bag.
Do you have? Hi. Do you have her email address? I'll just send it.
Yeah, I CC'd you.
And it's not good. I'm not logged into that email.
Okay.
So it's like 10:30, I'll peace out, but we're running. So I think 10:45. It should be tomorrow, and then run. Yes, absolutely. Of all that.
Yeah.
10:45, right?
Sharice.
Good morning. How are you?
So Alyssa.
I'm going to sit not directly
Oh,
on the
good.
mic. I don't like my voice.
What? Okay, yeah.
Thank you. Send it.
Oh, hey now.
What's that?
Hey, hi. I didn't think I was going to be able to meet you. Thanks for finding me in person.
I'm wazing it to see how long you've really.
It says 17 minutes on Google Maps. The problem is that Cherry Blossom Parade is going on right now, but I figure if they go north, and there's a little bit of a, I cut it too close. Hi, good morning.
Can I sit in the corner in the
Yeah.
back?
He's telling me 17 minutes.
Should I move over? No one's going to sit there. So 10:45
Ready
is
for
the latest,
FBI
I'll be
or
okay.
not?
Because I have lunch.
Okay.
I think we just, what we have been doing is to open it.
Sure.
Yeah.
Whatever you
We'll
need.
carve a little bit out of
Whatever you need.
I love this.
Yeah. Whatever you need.
No, that's right.
Okay.
Here. Do you want some water for the drink?
How are you doing? I am like ready to go.
All right.
Lunch?
I think you said we're
Like my first.
Okay, got you. We got it.
If anyone lost a pair of glasses, there's a pair of, you did. You couldn't see
She's been looking everywhere for them. She's been so distressed. She can't.
That's hilarious. She's so happy.
8 o'clock.
I would be happy.
8:45, like everybody.
Oh, there we are on the screen.
All right.
Everybody.
So you know, let me start introducing everybody and
They are,
try and get
yeah.
Therese to join us. Is that okay?
Yeah.
So we'll go ahead and get started while we're getting some electronics coordinated here. I think this is an interesting growth in SCUF this year as you look around the room and look at the faculty list and look at the people in the audience. I think pediatric emergency medicine ultrasound has discovered this meeting and we're very excited to have strong representation from really the leaders in pediatric emergency ultrasound join us this year at SCUF. They came last year to SCUF in Philadelphia, so Alyssa was there and had interest. And now, Alyssa, I'm proud to introduce my friend and colleague from across town, Alyssa Abo, who is actually now on the SCUF board of directors. So I will let, oh, fantastic, that was working out. So we'll have Alyssa introduce our panel and we'll talk about pediatric emergency medicine ultrasound.
Awesome. Thank you so much, Keith. Thank you, SCUF. It's really exciting for us as a PEDS emergency community to feel like we have started to arrive and that we are a panel this morning. And our panel is not only to talk about pediatric emergency ultrasound fellowships, but also how the adult emergency ultrasound fellowships could potentially improve their pediatrics. So just some quick introductions. At the end is Dr. Adam Sivitz. He's the medical director of the Pediatric Emergency Department in Newark, Beth Israel, Children's Hospital of New Jersey. And he's a current president of the P2 network. That's the PEDS Emergency Medicine Point of Care Ultrasound Network. And many of the panel members have either served on committees and board positions, past or present. So we have a strong presence here from P2. Dr. Jen Marin, who is sitting to my right, she's an associate professor of pediatrics and emergency medicine at the University of Pittsburgh School of Medicine. She's the director of the emergency ultrasound program, and she's the quality director for the entire hospital for point of care ultrasound, and that's the Children's Hospital of Pittsburgh. And I will also just mention she was the lead author with Resa Lewiss on the recent policy statement that I'm sure many of you have seen about point of care ultrasound by PEM physicians. Kaida Alade, who's next to Adam, is an assistant professor of pediatrics at Baylor, and she's also the director of pediatric point of care ultrasound there. And she was an integral part of developing their PEDS emergency point of care ultrasound fellowship, and that was also one of the first in the country. And she's currently spearheading a collaborative research project. It's a multi-center project aimed at creating a validation for PEDS point of care ultrasound examination. So hopefully she'll be able to talk a little bit about that as we go along. Lorraine Eng, who is also on our panel, is an assistant professor of pediatrics at Columbia, and she's the director of their Pediatric Emergency Ultrasound Fellowship in New York at Morgan Stanley Children's Hospital. And then we have Charisse Quantum joining us from Toronto, which is super exciting. She's an assistant professor at the University of Toronto, and she's the director of the Pediatric Emergency Medicine Point of Care Ultrasound program there at Sick Kids, and she's involved in a lot of national and international work as well, mostly focused on collaboration trying to establish standards for credentialing and curriculums in pediatric point of care ultrasound. So I think we'll hit on a lot of this today. And we're also going to do a poll everywhere. So we'll start with one of our questions, and then we'll transition to do some of the poll. Oh, you're actually ready to go. Okay, awesome. So if the poll everywhere is up and running, if you guys don't mind getting out your computers or your phones, however you've been involved with poll everywhere, we'll ask our questions up front, and then we'll go on. All right, so the first question is, did you receive training with pediatric patients during your emergency ultrasound fellowship? All right, so we're going to say about 70% yes and 30% no. Next question, do you currently train pediatric emergency medicine fellows? So not necessarily ultrasound fellows, but just PEM fellows. right, so about 40 yes, 60% no. Just, I know it's hard for you guys to see behind you and probably not so easy to see this, so I'll just let you know what we're seeing here. Are there currently requirements for scanning pediatric patients in your adult emergency ultrasound fellowship? Okay, again, we're seeing about 70-30. So 30% yes and 70% no for the adult emergency ultrasound fellowship training pediatrics. So this is one of the things that has come up for us, and hopefully we'll discuss ways to improve that. If yes, what percentage? So if you're an adult emergency ultrasound fellowship and you have a requirement for pediatric scanning, what percentage would you say you require?
Not just what's going to happen.
Either, yeah, so I mean, happens is fine. I mean, if you have a requirement, then hopefully they're at least doing that requirement. If it's not a requirement, then you can just sort of guesstimate what percentage you think happens. All right, excellent. So 0 to 25%. What percentage of time scanning pediatric patients and pediatric specific problems should be recommended in an EUS fellowship? So 0 to 25% is the overwhelming majority. How comfortable are adult emergency fellowships teaching pediatric topics? So we're seeing a little bit of everything. You guys can see that. Almost. Wow. Wow. That's almost a first, a quarter. All right. So excellent. Adult emergency ultrasound. Where are your fellows getting their pediatric experience? Interesting. So none of the general EDs feel that they see enough pediatric patients, which is interesting to us since like 80-90% of kids in the country end up being seen in adult EDs and not in children's hospitals where a lot of us are working. All right. So if you have questions, feel free to post them here and we'll try and get to as many of them as we can. Hopefully we'll answer them with the questions that we have come up with as a panel. So the first question we're going to start with, and the first set of questions, there's only 2 or 3, are going to be talking about pediatric emergency medicine ultrasound fellowships specifically. And then we're going to transfer to talking about the adult emergency ultrasound fellowships and improving the pediatrics. So question number 1, what makes a pediatric emergency ultrasound fellowship unique? And you can feel free in that to talk about your curriculums, your objectives of the PEM ultrasound fellowships you're running, and what you potentially see as the disadvantages or the benefits to a PEDS emergency ultrasound fellowship versus the traditional ones, which a lot of us were a part of. So I will say many of us on the panel did traditional adult emergency ultrasound fellowships, and now are spearheading pediatric specific ones, so can talk a little bit about both sides. So we'll start with you, Dr. Marion.
Oh, I was going to say, I would actually defer maybe to my colleagues. We don't actually have a pediatric emergency medicine ultrasound fellowship at my shop. So it's probably better to have you guys talk about what you guys do.
I guess I can speak first. So I'm one of the people that Alyssa was talking about where I trained under an adult program, but at the program I trained at, there was a separate pediatric ER. So I was still able to get a focused pediatric patient population. So I currently am the director of the Pediatric Emergency Ultrasound Fellowship, and I am in a large academic tertiary children's hospital. So the focus of our applicants is to train PEM physicians. We do look at EM physicians, but we, at our institution, we actually don't have a general EM ultrasound fellowship. So for our applicants who want a little bit more experience in AAAs and DVTs, we do send them over to what we call the adult ER because they don't see any pediatric patients, and they can scan with some of our colleagues over there because they're responsible for training EM residents. But for the most part, what makes us very pediatric focused is that we're in a tertiary children's hospital, and 99% of their scans are on pretty sick pediatric patients. So we have a good range of pathology in our patients to help.
And we do as well. At our hospital, once again, we're at a freestanding children's hospital. I'm at Texas Children's Hospital, and we see
a high number of very sick patients there as well. We have a ton of pathology. And so our ultrasound fellows are able to see everything they want to see as far as pediatric pathology, but then we do collaborate with different departments, as well as we collaborate with our adult ultrasound colleagues so that they can get that experience and more procedural experience. We send them wherever it takes in order for them to feel comfortable scanning pediatrics. Because peds aren't just little adults, and so it takes a lot more to learn how to soothe the families and soothe the patients and get the exam on someone who's screaming, kicking, biting, and spitting. And so we want them to come out and be able to do what they need to do in a timely manner. Wow, I'm generally very loud, so excuse me. And so I think at our shop, being as large as we are, and we have multiple institutions to scan at, we are actually opening another one next week. And so our fellows have a unique experience, but we also collaborate with our adult colleagues, other departments, and so that when they come out, they can see everything. Our ultrasound fellows scan with radiology, they scan with OB, they scan with cardiology, they scan with the adult hospital, they scan in our pediatric department, they work in our department. And so we want them to come out feeling comfortable wherever they're at, because if you work in our hospital, we have 24/7 radiology and ultrasound, but we want them to be able to work elsewhere and feel comfortable in making the decisions they have and forming collaborations with their the community colleagues that they meet. And so we think it's really important in pediatrics. And I did my ultrasound fellowship at an adult hospital and tried to tailor not seeing as many pediatric patients as I needed to there, but also having the opportunity at the hospital I was still working at to scan with pediatric patients. So I just think it's really important for pediatrics to actually scan on pediatric patients, the applications, all of them, as well as the pediatric specific ones.
So thank you. Kind of like Jen, I don't have a PEDS ultrasound fellowship spot at my institution, but I trained back in the day when there were no PEDS ultrasound fellowships. And so during my 3 years of my PEM fellowship, I was the adult ED fellows, ultrasound fellows, kind of pediatric fellow. So I was kind of joking, I didn't have my 1-year fellowship, I had a 3-year fellowship, and I've kind of taken that model to my shop. So we are more of the community-based model. We are the pediatric hospital within a general hospital. So I have my peds ER and my adult ER just a hallway over. So my fellows, my PEM fellows, I try to teach as if I was teaching them in a PEM ultrasound fellowship. So from year 1, they get the introductory course, and on every patient, every day, we're bringing the ultrasound to the bedside just to stress the importance of that continued use of ultrasound on a daily, regular basis. The goal of my program, the way I have it set up, is that I know that my fellows are going to be going out into the general ED world where there's not a lot of places, there's not a lot of standalone PEM places. And I'm from New Jersey. We don't have a central mothership hospital like a lot of these other institutions. So they're going into a lot of places where like they're training. It's a PEDS hospital within a general hospital. And so they need to be well trained to try to teach the rest of the faculty, which really have no ultrasound experience at all, and then bring their experiences to train up the existing faculty and to build ultrasound programs within those types of community locations.
Excellent. Sharice, let's see if we can hear you.
Can you guys hear me?
That's awesome. Yes, we
Okay.
can hear you really well. Do you want to
Perfect.
talk about your PEM ultrasound fellowship up in Toronto?
Sure. So I'm probably the only, I think I'm the only one here who trained in a PEM focus fellowship, and that's at kids. And so I don't have experience in the adult world so much. And so hopefully this is not too biased, but in terms of actually speaking about how it's a bit unique, I think the applications, I mean, I think everyone can agree the applications are a little bit different in what we focus on in pediatrics. First of all, and a lot of that is not necessarily taught right away at the beginning of fellowship, but once you start working as a PEM physician, you start to figure out which ones are the most useful in your context. And I think that's a bit unique because our focus is a little bit different. We do a lot of lung applications, ocular at our center, and a lot less procedural stuff, especially with a lower pathology rate, which I think we're going to talk about later in pediatrics. And so it's not, and on top of the fact that it's not just a technical thing, I think part of POCUS fellowship in adults and also in pediatrics is also establishing the base knowledge of all the evidence within your scope of practice. And with the lack of good general pediatric or PEM POCUS literature out there, I think some of the focus is how do we then collaborate with other programs like everyone else on the panel here to establish the research that's out there. So training our fellows to actually pick out the right topics, knowing the literature and pediatric POCUS, and then developing the research behind it, as well as how do we develop the curriculum and education for PEM POCUS. And that's what we're struggling with as a whole group in the P2 network as well. And so I think that's some of the uniqueness of what PEM Ultrasound Fellowship brings. In terms of what we do with our fellows, other than that, for adult exposures, we send them to adult hospitals. So it's almost the complete flip side to what the adults do, I think. And we don't get too much adult exposure at all. We're quite isolated, although we have several adult hospitals who ultrasound around us.
Excellent. So are there any questions right now in the audience from people who are trying to start pediatric emergency ultrasound fellowships, or those who run them? Anybody want to weigh in? We just want to open up for discussion. Romo.
One quick question. So for the adults who aren't in the PD world, can you just talk about the scans you do? Not the ones you teach, like obviously interception we talk about, but you can't be spending half your day looking. What is it that you do on a daily basis so that we get a better idea?
Yeah, that's a great question. And I think that the answer is very specific to where you practice and what kinds of patients you see. So for example, my daily practice, I would say we're doing a lot of soft tissue, a lot of fast, a lot of hips, a lot of intussusception, and a lot of peripheral IVs. That's sort of mostly what's in my wheelhouse and what I try to teach the fellows. At one point, we were teaching them nephrolithiasis and gallbladder, but we don't see that much. You know, we see some, but not enough to really, I think, get people competent in it. So it's not something that I'm doing on a regular basis. So I would say those are really my core applications in my practice, given my population.
And I think with my population, we do a lot of resuscitation and hypovolemia. And it's the game changer for us. And so we get these kids who come in tachycardic, not necessarily hypotensive, and trying to figure out, so we modify the rush exam and do some pediatric version of that. And when we're looking at the heart, the abdomen, the lungs, the IVC, and trying to differentiate what goes on. And that has been one of the things that's drawing other people into scanning in our department, is finding, the kid who comes in with vomiting who's been abused and has a belly full of blood. And then it's like, oh my gosh, I need to learn ultrasound too. How did you find that? Like, excellent, let's get on this. And so we do that as well, just regular cardiac, intussusception, peripheral IV has been amazing. And so we trained our physicians in the ER who then trained nurses. And now that's just like been a great thing in our department as well. And those are the things that we use most often. Appendicitis, we look, but our radiologists aren't giving us that billing yet, but we still play with it. But it's not one of those that we use for clinical diagnosis at our institution yet. Intussusception as well, we look.
Yeah, again, I think this is institution dependent. We're a level 1 trauma center and do cardiac transplants. So we do a lot of fast, a lot of cardiac. We have traumas that come in with cardiac history. So then you don't know what to do with the pericardial fluid, but that's another story. We do a lot of MSK. We actually do a lot of API, and we do a lot of OBGYN. So our fellows who were hearing the talk yesterday about not being able to meet that milestone for transvaginal ultrasound, they're like, I want to work there. Because our population, we do a lot of first trimester OB ultrasound. So I think it's a good array of applications.
Adam is nodding because he's in a similar situation.
It's a New Jersey, New York thing. Yeah, so like the pelvic pregnant applications are right in our wheelhouse, but also acute abdomen. Someone made the comment during the journal talk that the incidence of disease is only 10% in that pneumonia population. But to be honest, if you look at any of the radiology resources, the positives for pylorix, for intussusception, is only 10%. When you look at everybody who goes to radiology, who comes back as positive. So I think you have to have a high index of suspicion. So all my fellows are doing bellies all the time. If anybody's vomits, you're putting a probe on their belly to see what's going on. MSK, lung, there's a lot of lung going on in our institution, especially now we just came out of bronchiolitis season. And again, that goes to that chest article that Jim just mentioned. We're not really sure what we're going to be doing with those subpleural consolidations. I think it's a mystery kind of to everybody, but unless we start looking and seeing what they do and how they evolve, we're never going to know. We don't do a lot of nephrolithiasis. We do a lot of gallbladder. We have a highly obese pediatric population in general. And if you're not looking, you're going to miss it. I've had a number of patients who've had months of belly pain, have gone to, pediatricians, have switched pediatricians, gone to GI, and they just got stones. And if someone looked 6 months prior, they would have found it. So I think, Pediatrics are, we say it's not little adults, but sometimes they have adult disease.
Yeah, for us, I guess, again, it's context specific, but we kind of separate things into kind of the game changers, as Kaida says, and do a lot of recess as well. And I feel like that is one way to really convince your fellow colleagues to really start to learn ultrasound. But on top of that, there are the ones that I find kind of replace the physical exam that you just can't do in kids. So one of the other big game changers I have found in our center is ocular ultrasound to look for papilledema or sonographic papilledema. Although the evidence is not quite that strong yet, trying to look and do a fundoscopy on a 3-year-old who's screaming is just impossible. So for a lot of our physicians, they have found that that is a game changer as well. And we've caught several brain tumors that way, or space-occupying lesions that way in the last 2 years. So that's one of the big ones. We don't do so much pregnancy ultrasound. In fact, I think we've only seen maybe a dozen in the last 3 or 4 years, I would say. And a lot of them go to our peripheral hospitals. And same with things like peripheral IVs, we don't really tend to do that so much. Our nurses, we have a very good success rate, and we have a very good IV team that just rushes down very quickly. So very little chance to do that. But everything else, I mean, I think MSK, INTUS, API, we do. Some of them we try to avoid a little bit because of the political atmosphere with radiology. So that's also site specific as well. What you try to avoid and what conflicts and battles you want to fight at the time.
Excellent. Thanks, Cherise. So we've talked a little bit about our PEM fellowships and sending to adult EDRs for more exposure. Do you think that that's, what do you think the drive is behind that? Is it pathology? Is it just exposure? And if you're doing that, what percentage do you think your pediatric emergency ultrasound fellows spend in an adult environment?
So I think one of the driving forces for us sending our fellows over to the adult ED is that you guys do lots and lots of CAT scans. And so for learning, there's nothing greater than having a great gold standard, take the gold standard as you want, but a great gold standard follow-up to see how your ultrasound compares to a CT. We don't do a lot of CTs in pediatrics. We're actively trying to avoid it. And I think at a lot of places where you're training, there's reluctance to do training on patients who aren't going to radiology, or aren't getting a gold standard test. Like it would be hard to do an echo on a patient who then is not going to get followed up by cardiology. But on the adult side, you guys get echoes on patients all the time. So beyond just the pathology that you see on the adult side, it's also just the amounts of testing that get done over there compared to the pediatric side.
For the PEM fellowship, we have a longitudinal 3-year curriculum for our fellows, and I try to have them go to a lot of our different institutions across the university, and the purpose of that is twofold. So one is pathology. The reality is that there is not as much pathology in kids, and so they know their normals really well, but I try to get them pathology. But the second thing is that I like to have them have other people training them and other people describing and teaching certain things, because I feel like for me, that was very helpful when I was learning to have different teachers and different mentors. And so I like for them to not hear my voice all the time and not have me be the one to tell them, hold the probe this way, anchor your fingers, et cetera, et cetera. They can have someone else give them their nuances and their little pearls.
As far as the PEM POCUS fellowship goes and the adult outreach that we have, the goal would be at our places to spend about a month away, longitudinally throughout the time, because in the adult hospital, it's like an ultrasound playground. You can talk to people and scan all sorts of different pathology procedures, and the setup that our adults have, we have a great relationship, and our fellows are credentialed at the adult hospital as well, so they can go there and dive right in, and we can go back and forth between the adult ultrasound fellows and our PEM POCUS ultrasound fellows and trade. And so it's a great experience for them to get there and be able to do procedures and see the adult processes. Yes, I did an adult fellowship, and I've only seen 2 AAAs since I finished my my POCUS fellowship, and it was on the same kid. I've seen the DVT 3 times, and that girl just needs to stop coming back to my hospital because once again, it was the same kid. But it's great to have that. It's great to have that knowledge and be able to use it, because then as they're waiting to do other things, it's something that we can teach and practice. But that's not something that I can teach and practice at my shop, and we have to send them elsewhere to get that.
We don't have a standard requirement for ultrasound fellows for their adult rotation. It's more as a per their interest, however much time they want to spend in the adult ER, because I actually think that our fellows feel like they have a decent amount of experience and exposure to pathology. But when they want more focus and scanning on AAAs and DVT, then I send them to the adult side. And I always tell them, like, once you wrestle with a 300-pound patient, your little 6-kilo patient is a piece of cake. So it definitely puts things into perspective for them.
Yeah, one other thing I'll say is that we have them spend some time in our general emergency department, but a lot of their time now is being spent in some of the other services. So they go to our critical care, our ICU at the VA and our transplant ICU at, one of our hospitals, and they're going up to rheumatology and learning MSK, and they're spending time with the MRI vascular access guy and just like doing IVs that way. So it's not so much necessarily bombarding my general EM colleagues, but really spreading the wealth and getting them to learn different techniques and different indications from people who are doing sort of that same thing over and over.
So we're getting a lot of questions about curriculums. So do you feel adult emergency ultrasound fellowship should include pediatrics as part of their curriculum? And if so, what would you say the core application should be? And we'll start with that, and then we have a lot of questions that sort of go along that theme. Sharice, do you want to start off on that maybe?
Okay, sure. So I think it should be part of it, at least. I mean, I think part of it is also just knowing the literature and how to teach it, but saying that adults ultrasound fellows need to master all the pediatric topics, I think is a bit difficult, given, like we've said many times, the low pathology rate. So I don't know about teaching mastery, but maybe at least incorporating in your curriculum so that you have a good base of what the evidence is and what the technique is. And at least if you are able to speak about it, I think at the very minimum, that would be needed in the curriculum. It's hard because I never did any adult medicine at all. All my training is in pediatrics. So I'd love to hear what the other panel members have to say about that.
And I feel like if you're gonna be taking care of pediatric patients, we've all seen what a game changer point of care ultrasound can be in our management. So why not extend that to the pediatric patients if you're taking care of them? And as Alyssa said, 90% of our pediatric patients are seen in community hospitals, which will be taken care of by non-PEM trained people. So knowing what their diagnosis is, when to transfer if you need to and escalate care can be huge in terms of care for your patient and also your ED length of stay. So I think it's good to have exposure and know the literature, but at least have a basic understanding. Like if you are worried about pyloric stenosis or intussusception, you can at least get started and look for free fluid and at least know the basic steps and what the indications are for transferring.
I completely agree. And I think your EM residents are coming out of residencies with a vast amount of ultrasound knowledge. And so in adding on what you can give them and what you can teach them in an ultrasound fellowship, as she was saying, the majority of pediatric patients go through the general ED. So having some mastery of these pediatric applications is very applicable. And I think that very useful for your general ultrasound fellows as they're trying to get advanced topics. It's not necessarily advanced in our world, but if it's something they're not learning through their regular EM residencies, it would be considered advanced there.
So which applications would you all add, right? So an EM resident is comfortable doing a fast, they can do a fast on a pediatric patient. But if we had to give a top 5 to the audience, one thing that came up was acute abdomen. Okay, so pediatric abdomen obviously has its differences, but what else?
I think the pediatric hip is really helpful for me and really changes my management, right? If I see fluid or not. So I think the pediatric hip, and it's such an easy exam to do. And I think intussusception also. So I would say those two would be the biggest. And they're not difficult exams either. Like appies and pylorics, I find. Earmuffs, Adam. Adam's like the world's expert on pediatric abdominal ultrasound. I think that pyloric stenosis and appendicitis can be difficult. So I think those two are just not difficult to tack on to your curriculum.
Can I just add something?
So I mean, it's in your ASAP document, the acute pediatric abdomen is part of the core. It should be included in all your training programs. It's the most common surgical conditions, right? These are the things that you're transferring to your pediatric facilities. Once you want to know that they actually have them before you make that transfer, and then, we don't have to say 2 hours later, no, the ultrasound was negative, the kid's fine, right? These should be part of your guys' core education. I think for other things, lung is very important. I think lung in pediatrics is very different than what you see in adults. When you guys see tons of B lines, it means something different than when we see tons of B lines. When you're using linear probe as opposed to curvilinear probe, you're getting a lot more detail. You're finding a lot of these subpleural consolidations. You've got to figure out what you're going to do with them too. Not to mention the whole difference between viral pneumonia and bacterial pneumonia. What is atelectasis? A lot of questions that we're still trying to answer. And then, as been mentioned a couple of times, just the resuscitation. There's something different about looking at a pediatric heart, which normally is beating 160 times a minute, and being able to make some determination about whether that's good function, poor function, and correlating that to what you're seeing on the lung ultrasound and IVC. So the kids coming in shock. I know that's probably something that none of you want to see in your regular EDs. You want to push those kids out to the ped side as fast as possible, but when you have them, you gotta know what to do with them.
Can I just add something really quick?
Please.
We just recently had this discussion with our adult colleagues, and I think the importance of, again, knowing the literature and how it differs in pediatrics, because, for example, the FAST, we just recently spoke to some community adults, ER docs, and there was just a lot of misconceptions about how we apply the FAST in trauma in pediatrics. And I find personally that FAST is definitely very useful, and it's not the technical aspects that we need to teach some of our adult EM colleagues, but how do we apply it? What does it mean when we actually see free fluid in the abdomen? And also, I find it actually more useful in the non-traumatic patients sometimes. Like a FAST in a medical recess can really be can really change what you decide to do in that recess than in trauma, where we tend not to go to the OR for a lot of patients. A lot of medical management there as well.
So we're going to switch to answering some of the poll everywhere questions. One of them that has come up is about training. So if you're an adult emergency ultrasound place that doesn't have enough pediatric patients, what kind of partnerships can they look to establish to get their emergency ultrasound fellows some pediatric experience? And then the question went on to say, do you host emergency ultrasound fellows at your shop now?
Yes.
So,
we do.
This is another one of my reasons why I think that you need to have a good pediatric education as part of your core EUS programs, is that I don't think that we necessarily have a critical mass of pediatric places with enough people doing enough teaching, and you guys have an abundance of it. So in a lot of ways, we kind of look to your community to know some of the pediatric applications, and then bring that to your local pediatric centers and, hey, do you guys know that this stuff is going on? You really should know it. You get some interested fellows involved. That interested fellow becomes a local champion, and now you have a resource that you can send your people to. But I think, you guys are a decade ahead of us in pretty much everything, but one of them already is the training and the education. So we need to rely on you guys some of these times to pick up some of that new training.
And if you're in a place that has pediatric ultrasound training, it's great to form those relationships where you can send your fellows back and forth, and you can host their fellows, they can host your fellows, some scanning time, joint conferences, whatever the case may be. Those are always great relationships to build. And then there are places throughout the country where that they can host adult ultrasound fellowships, like Texas Children's Hospital can host adult ultrasound fellows. But honestly, you can make those relationships, and it becomes very beneficial between all the institutions, because it's great to have places to send, the pediatric fellow who's out looking to do more adult stuff because they're going somewhere in the community where, you have to see adults as well.
Yeah. I think I'm just echoing what everyone else is saying, but look within your institution if you have your pediatric ultrasound experts. But also, if you can look outside your community, look in the local hospitals and see who the other leaders are. I'm lucky to be living in New York City, where there's a plethora of ultrasound leaders and experts. So my ultrasound fellow we have a copy of St. Luke's guest speakers and lectures, and he'll on Thursdays, if he's free, he'll pop down and attend some of their lectures, and he'll go and scan with them just to kind of change things up. So we definitely utilize our local resources, and it's definitely a give and take community.
Excellent. So one of the other questions is, I'm just going to read it. Since PEM fellowships are 2 to 3 years, is there a need for another PEM POCUS year, or is there a bigger need for enhancing the PEM fellowship curriculum by integrating PEM POCUS?
Yeah, so that's a thing that's a question that has come up a lot and that we're talking about in the P2 network, which is the Pediatric Emergency Medicine Point of Care Ultrasound Network. And I'll just say back to the other question, if you're interested in pediatric point of care ultrasound and what's going on and what's hot and how can I do this, I would recommend joining P2. It's free. And there's a lot of good information and there's a lot of good potential collaborations. And so what's happening and the questions that are being answered and things that we're struggling with are being discussed. And we would love to have your input as well. So it's not just for PEM POCUS people. But specifically to this question, have like a brain freeze right now. The ultrasound fellowship. Yes. Sorry. Okay. 2 years versus 3 years. Yeah. So that's something that came up internally for us. We talked about having a pediatric emergency medicine point of care ultrasound specific fellowship, extra year. And so you're talking about 3 years of peds residency, 3 years of PEM, and then an extra year, which is 7 years. That's a really hard sell for PEM people. And so we decided for us, it was better to just enhance our PEM fellowship, the ultrasound experience. And so that's where our focus is. And it's something that we're all discussing and struggling with because that's a really big time commitment. And I think that as more ultrasound is being incorporated into PEM fellowships, there may be less of a need for that exclusive year. But most PEM fellowships are not set up where there's enough of robust training that there probably currently still is that need for the extra year. And that's why most of us did another year of training because we didn't get it in our PEM fellowship. But personally, I think that as we're now developing our PEM POCUS curriculum within the core fellowship, I think there's going to be less of a need for that extra year.
Right, I think that my ideal world would not have to do another year, a 7th year of training. So we've definitely spent a lot of time on our PEM fellows and training them so that our goal is that every PEM fellow who graduates is at least comfortable in the basic applications of ultrasound. But even for EM residents who are ultrasound trained, there's different indications for doing an ultrasound fellowship if they want more administrative or research or taking on more of a leadership position. So when we interview our PEM ultrasound fellowship applicants, we kind of feel out if they're interested in just learning how to hold a probe or if they want to become a leader. And I think the training and the focus is different, but ideally it would be to train all of our PEM physicians. And then if you want additional training in terms of leadership and research, all that stuff, that would be the point of ultrasound fellowship. But I think we're still a few years away from that, but I try to incorporate that into some of our PEM fellow training.
Does anyone want to talk about the idea of the combined PEM and ultrasound fellowship? I know that it's an area of big controversy for us as a group. But Adam, I know your experience was something similar to that. No, and when I was a PEM fellow, there were people who were doing PEM critical care, PEM ID. So this idea of doing PEM with something else is not foreign to us. But PEM ultrasound, there are a few places that are doing that now. And just sort of your thoughts on that, and would that require maybe an extra 6 months instead of an extra year?
So yeah, I guess I'm still kind of the black sheep here, but I think the importance of having having ultrasound within the PEM fellowship curriculum is to develop that critical mass of ultrasound savvy clinicians that can staff the pediatric EDs. We've had research calls where we've been talking about doing some studies on shock, and some of the places have said, we have like 15 attendings here, and there's probably 13 that wouldn't even know what to make of an echo. Is it moving, not moving? What does that mean? They're not comfortable with that as of yet. Like, that's ridiculous in this day and age, right? But that's because we don't have that critical mass. And that's why it's important to have enough ultrasound training within the 3 years that we can reach there. I mean, I agree with what everybody says about the extra 1 year of training, that we need to develop leaders. You need leadership. You need people who can interact with, the upper echelons, these children's hospitals, because that is a very thick ceiling to break through a lot of places. And there's a lot more politics entrenched, I think, in the pediatric standalone places than in the general EDs and the adult hospitals. So I think it's important to have that extra year of training. But to get out there and to do ultrasound, you can do studies without a fellowship. There's not an ACGME accreditation as of yet. If you want to bill, it doesn't matter if you did that extra year or not. So there's a lot of reasons why you don't necessarily need to have that year, but you absolutely need to have that kind of training to practice modern medicine.
One of the next questions says, if you're a PEM at an institution where radiology does not support you doing abdominal scans, pyloric, intussusception, epi, or you're adult trained without good exposure to kids, how do you recommend getting good at performing these higher risk scans?
Do it. You scan on, if you send someone to radiology, whatever your practice is, and you have to follow the things that radiology says, if you have someone who comes back with an intussusception, you scan the intussusception. You don't have to bill for it, but you ask the families if you can scan them. They're not going to usually say no. If there's something positive and you know about it, let your fellows send them into that room so that they can see it. You see enough regulars, and then so when the abnormals pop up, just because they had something done in radiology doesn't mean you can't approach them and say, you know, I would like to learn. And most parents respond to that. They're like, hey, I'm teaching a doctor something. You can scan my kid all day long. And so it's a matter of how you approach the families and ask them, but you seek out those experiences.
Let me take that and throw it back to you guys. How many people actually do bowel sonography? Right. Okay. There's nothing different about the pediatric bowel other than we're looking at it with a linear probe. So every time you're doing bowel sonography and looking at the stomach and looking at small intestine, looking at large intestine, you're learning the things that are important for doing the pediatric abdomen. You're just, not finding the hypertrophied pylorus, but you can find the normal pylorus a bazillion times. When you see it abnormal, it's going to be very obvious. The same with intussusception. Nobody misses intussusception. It's like the easiest thing in the world to see. Parents behind your shoulder are saying, hey, doc, what's that? They know that it's abnormal. The appendicitis, that is a little bit difficult, but there's plenty of patients out there who come in with right lower quadrant pain that's undifferentiated that you have to practice on. This is not an uncommon presentation for you guys to do ultrasound training on. You just need to bring the probe to the bedside.
So one of the next questions we're going to talk about is competency. Charisse, maybe you want to start. How do you establish competency in your PEM ultrasound fellows, and even your PEM fellows for that matter, if you're doing that as well?
So that is a very difficult topic. I think there's very little literature on how to establish competency. I think right now in Canada, our Royal College, which is I think the same as your ACGME, is really pushing for all of our residencies and fellowships to become competency-based rather than time-based. So there is a bit of pressure that way, and we're trying to stay ahead of the curve. The difficulty is right now all our guidelines are based on a numbers-based system where you scan 50 carts and you're competent, or whatever it is that's written in mostly the ACEP guidelines and also the AP guidelines. And what I'm trying to do, and part of my research, is actually kind of turn that on its head and say we shouldn't maybe be looking at numbers alone, or a set number, but maybe just looking at individuals and then finding the right scales to rate them. So having people practice until they become competent, whether it's 8 scans, whether it's 100 scans, it really depends on the learner. So that's where I'm trying to focus, but given that none of the evidence is out there yet, and we haven't finished any of these studies, I think we do have to rely on the number of scans, making sure people are good at image acquisition, interpretation, and then understanding limitations of all the applications and working into your clinical workflow. That's what I have to say about it.
Thank you.
I agree with Charisse. I think we have numbers. So we have a table of all the core applications that our PEM fellows are supposed to do. And so we start with numbers, but we also have an OSCE type exam that they do at the end. We're moving it to their second year, at the end of their second year, that my associate director has created. And so it's a, bedside exam. We have pediatric models and it's one-on-one. And we basically say, okay, here's your scenario. What would you do? And they have to verbalize what they're doing, which probe would they select, why. We sort of pimp them while they're doing it. And so we get, real-time observation of their skills to really solidify whether they are in fact competent. Is that the right way to do it? I don't know. That's just what we've adopted. And I think it's helpful because I think it also really identifies some subtle deficiencies that them just doing X number of scans over a certain period of time might not capture.
Anybody else want to add anything? No? Okay, so let me grab one of the next questions. So here we are. How should an adult ultrasound director approach training credentialing of PEM physicians, not necessarily fellows? So you're at a place where maybe there's not a PEM POCUS champion and an adult emergency ultrasound champion is getting asked to help train PEM physicians.
mean, I guess my personal opinion would be to start with how would you train and credential a new faculty member who did not get training, or maybe an old faculty member who's in your division who wasn't trained? You know, sort of start with that and then just modify that in terms of applications.
So you would probably want to ask that physician what their most common thing is that they see where they would want to use ultrasound and really train them by those applications. You know, we know with ultrasound that, you know, it's kind of like crack. Like once you get used to one probe, you want to use it more and more, and you get used to some of the other tricks of the machine, and then you want to use other probes for other things. But you got to start very, very focused, especially for someone who's never used it before. You know, I've seen some people who, again, we do tons of pelvic stuff, and all of our clinicians are very adept at it. And then one of them had a soft tissue application that they wanted to use ultrasound because they felt that they were adept in ultrasound, but they're using a curvilinear probe to look at a soft tissue abscess. You know, they had the right idea, but they don't have to apply it. I think the other thing that's very hard is that you would need a lot of hands-on, like one-to-one kind of interactions with them. I think that's really the most important thing with training, is kind of being next to them. So it's one thing to, you know, give them the lecture and give them the talk and give them, you know, the resources to look up, but there needs to be some time that you spend with that clinician, or the clinician can spend with you, which would need buy-in from the director if it means coming out of the department during, you know, non-clinical time to get that education. So, you know, getting good buy-in from the PEM director at that place to let that physician get the training would be just as important.
Right. I think a lot of how you answer that question depends on what the scenario is. Is the PEM person approaching you asking to be trained, or is your director saying you need to train the PEM person? So I think getting your director buy-in, a lot of what Resa was talking about yesterday, getting support from the top down can help, you know, provide you with the infrastructure to train all of your attendings. And the PEM position shouldn't necessarily be treated any different, as what Jen said, as any of your other new attendings. So maybe aim for the low-hanging fruit that is especially relevant to pediatric population, like bladder volume. No one wants to cath a baby again if they don't have to, or even soft tissue ultrasound. Those are super easy applications that don't require a lot of 3D knowledge or understanding, and it's pretty easy to understand.
So we're going to wrap up in the next few minutes. So we're going to open it up to the audience to make sure that we're not missing anyone.
Classify them with a test before and after. Out of that. And then classify people into specific. How do we design clinical pathways? But most of our learners into this specific. Beginning surgery. So we have these learner outcomes, and then the next step would be, how do we turn it into a component to break it up, and then we could actually design pathways for education.
Excellent. Are there any other thoughts, comments, questions? I think the last question we're going to end with, someone said, what is your case zero, the case that made you a PEM POCUS believer? So I saw the question, so I was thinking about that for myself. So I'll answer first, so you have a little time to think about it, what it is for you. But I was a PEM fellow, and we had an ultrasound machine that pretty much sat in the corner with dust on it because nobody was really our champion at the time to train us. And I remember seeing kids getting sedated with ketamine, and then we were, you know, cutting open cellulitis. And I just thought, this is not a good standard of care. We're risking their airway, and obviously we use ketamine all the time. We believe it's a safe medicine, but I still thought the resources and all of everything and the safety for the child to go under that sort of sedation, for us to not even be confident about what we were draining, I thought we could do better.
Well, I guess I'll tell you my case zero, but my first thought when you said that was like the reason that what really sold me was that Anthony Dean told me to do it. Like if AJ Dean tells me to do something, I do it. So that was my case zero. But the actual case, I think for me, that was like, okay, this is really important. And I try to share it with a lot of my colleagues who I don't think are as passionate as at ultrasound. Is briefly, it was a 17-year-old very complex patient who had cerebral palsy and seizures and a shunt and a G-tube and a trach and all kinds of stuff, and history of urosepsis, and came in febrile and tachycardic and hypotensive, and we all thought he had urosepsis and gave him fluid and a little more fluid, and his vital signs wouldn't change, and he was persistently hypotensive and tachycardic. And shame on me for not going in earlier with the ultrasound machine. But at that point I said, what's going on here? Let me go look at his IVC, and proceeded to do the rush exam and to find that he had an enormous pericardial effusion with tamponade. And that for me really totally changed my practice, totally changed my mindset, and was really the case for me that did it.
I don't know if I have a case zero in terms of what prompted me to do an ultrasound fellowship, but one of my case zeros that definitely solidified that I definitely made a good decision in doing a PGY7 was maybe a week or so into my first attending shift, and someone came in, they're like, hey, can we get an attending to evaluate this patient with chest pain? I go in, a 16-year-old male complaining of chest pain. I listen, I don't hear a lot, and I'm like, oh, I'm at Columbia, maybe it's dextrocardia. So I listen to the other side, still not a lot of sound. So I lift up his shirt, and he has a mid-sternal sternotomy scar. I'm like, what's that from? He's like, surgery. I'm like, when? He goes, 2 weeks ago. I'm like, what kind of surgery? He goes, I don't know. Turn to dad, and they're like, I don't know. So I'm like, all right, someone get vital. And I like grab the ultrasound machine, I put the probe on, and he's in tamponade. So at that point, I've been attending for about a week, and I like grab a resident. I'm like, how do I call everyone? How do I get everyone down here now? So cardiology came down, and I was like, this patient, and I showed them my effusion, and they're like, oh, you guys do that now? And I was like, yes, we do. So that was a big case for me.
I didn't have a case zero when I was in PEM fellow. I had zero exposure to ultrasound until our third year. They opened up a rotation with our adult hospital, and I went and spent a month with some very infectious people that I was like, oh wow, ultrasound is amazing. This is wonderful. I want to do this forever. And I said, well, no, maybe it's just the people I worked with were amazing. I don't ever want to do this again. So I stopped ultrasounding after that month, just to make sure it was ultrasound that I enjoyed and not the people that I enjoyed. And so once I realized it was ultrasound, I went back and did another 2 weeks at the end of the year, and then ended up doing an ultrasound fellowship, and then have had all of these experiences with tamponade and blood in the belly and it's great. All those cases are wonderful, but just for me, it came from having no experience and then spending a month in an adult hospital. I mean, I had been there before, because as a PEM fellow, you have to do them, 3 months during the time. But just this ultrasound month that I did there, it was amazing, and the people were great. And it was you guys that helped me to change my mind.
Yeah, again, no patient zero, but the patient zero is every patient that I would have sent home had I not have ultrasounded them, and all of them ending up in the OR, in some short time later, and tamponade, myocarditis, appendicitis, pylori, every acute abdomen. Getting seen by attending surgeons who said it's okay to send this patient home, getting seen by great clinicians who, I love forever. I wouldn't call them up in the middle of the night to ask them a question, but would have gotten sent home had you not put on the probe. The realization that what they teach you in medical school with your physical exam school skills and application with labs is a really limited way to practice when you have such an advantage of ultrasound at your side.
All right, Charisse, round it out for us.
Oh, I don't really have a case here either, but I just remember several recesses, again, where we ended up finding either congenital heart or cardiomyopathy, and they presented, and the initial workup is always, or the initial management is always fluid, and that stop fluid boluses within probably the first or second bolus, or even before that, and starting pressors and cardiology really early. I can remember at least 2 or 3 cases like that in my second year of fellowship. So it's not that exciting, I guess, since that seems to be the index case for many people.
Awesome. Well, thank you, Keith. Thank you, SCUF. Thank you, everybody.
Great.
Thank you.
Thanks very much. We're going to shorten our break, and we're going to come on back down here at 10:50 to start talking about critical care ultrasound. So thanks again to our focus panel. Appreciate it. That's fantastic. Very, very nice to finally meet you in person. It's really well moderated.
How's life?
It's good. It's great to
Things are
see you.
good.
Good times, good times.
Good critical mass now.
Yes,
I like
yes,
it.
he's here.
Thank you. That's great.
Hey, Keith.
Nice to meet you too. Thanks.
Yeah.
So we
Yeah, I heard. It's all good.
you have more stage time. It's good. You're
No,
about to share with
Yeah.
I
Thank
you.
you.
You're so good. I texted him like late last night. Mike stuck in Atlanta. I'm like, hey, man, what are you doing? He was like,
He did great. He did fantastic.
he was a victim of his own success, I think, though. There's a lot of people on there.
Yeah, well, the trainer's fun to play with.
Yeah. What's going on? How are you?
Can I get one question into the poll everywhere?
What's that?
Can I add one question?
You absolutely can.
How do we do it?
I don't know. No, let's see what we can do here. So you want to start. Alfred, do you want to just start with Poll Everywhere for your stuff?
Yeah, sure.
Okay, cool. Then we'll do that. Do you have slides or?
No, I think we were just going to.
You were just gonna panel.
Well, we had 4, so we were, there's just like all the stuff we were going to talk about is not really slide friendly. So we were just going to go with.
It's just looking for my interwebs. Come on. There we go. Hi, how are you? Good to see you.
Good to see you. So my
Should we shut this up here? How do we stop broadcast?
Well, not stop it, but mute it.
Yep.